Good afternoon. Been given 10 minutes, so this is going to be relatively not a real deep dive, but a little bit superficial and try to keep it simple. So I do have several disclosures. The kind of relevant ones are regarding Profound Medical and the TULSA procedure and Avenda Health, both of which will be mentioned during my presentation. So learning objectives really to kind of help everyone to understand on a kind of basic level the factors involved in determining ablation volume and a margin. Also understand the impact of ablation size on cancer control and the impact of ablation size on the quality of life factors. And we've had a lot of great talks already, so a lot of these topics will have been touched on already, but there are really some key considerations when determining ablation size. Technical ones such as where is the cancer, how big is the cancer, and what technologies do you have. Dr. Taneja just gave a great talk about how do you target and match those therapies up to where the cancer is and the size of it. But I think it's also very important to keep in mind patient goals, especially with focal therapy. Many patients are very particular, and they're coming to you for a very specific reason. They want to preserve their erectile function. They want to improve their continence. Those are the main things that we talk about, but there are other factors. They want to perturb their ejaculatory function, their ejaculatory volume, the color of their semen. There are a whole lot of different things that patients will talk to you about that they're very concerned about preserving with ablation therapies. In addition, several of the ablation therapies, especially as you start ablating more tissue in the prostate, can help improve BPH symptoms. There are secondary benefits of some of these ablation technologies. So cancer location and size does dictate the ablation approach. So if you have a small lesion at the left posterior lateral peripheral zone, you can do a focal ablation, a hemiablation, or a hockey stick ablation. If you have multiple cancers, I know we're talking about focal, but I think you still can consider a hemiablation for patients that have 2 lesions of cancer. Like, are they as good of a candidate? No. Are they more likely to have additional disease and a recurrence? It's possible, but some of these men are very determined to have an ablative therapy. Similarly, you can even have contralateral therapies. I think the main concern with cancer location is what are our critical structures? And this has been touched on multiple times previously, but the urethra and the neurovascular bundles are really our critical structures that we want to try to limit the damage to. And finally, if you have a tumor with bilateral neurovascular bundles at risk, is this really someone who is an ablation therapy candidate? I wouldn't say no. Is a focal ablation appropriate? No, you're doing 2 bilateral focals for a man. You're going to have the same negative impact on their sexual function. So then you really need to get to the question of, is an ablation therapy the same treatment as surgical? Are you getting the same tissue destruction and cancer control with an ablation technology as you are with a surgical or radiation treatment? So technology considerations. Dr. Taneja went through a lot of these. The point that I wanted to make was just sort of over here on the right, like who can be focal and who can be whole prostate. So we're talking about regional therapies as a comparison to targeted and focal therapies. Whole prostate therapies today are really kind of TULSA and cryo. I'm going to go through some of the data. HIFU has previously been evaluated in whole prostate treatments, but then you get to these others. And Dr. Taneja had a much nicer looking slide that had this graphically represented, so I'm glad I took a picture of that. So margin call. Does size matter? Does the size of the margin influence cancer control? Does it influence our side effects that we see for patients? And these are 2 very different lesions, right? One is right on the nerve bundle, and one is at the anterior fibromuscular stroma. One of these you want to treat when you're just starting, and one of these you don't necessarily, depending on if you're trying to preserve the guy's sexual function. But MRI alone, as has already been mentioned, is really inadequate. We know that there is significant, and Dr. Taneja's study is here, but then also a couple studies from the data out of UCLA. We really do need a 1 centimeter, 9 to 10 to 11 millimeter margin if we want to treat the vast majority of prostate cancer. And this is MRI to whole mount pathology correlations. And we now are able to even personalize that a little bit more in addition to Dr. Turkbay's AI discussion this morning. There's also AI with Avenda Health, and they've published this recently, looking at using AI with multimodal margin prediction technology, looking at T2 images, the fusion biopsy data, as well as whole mount pathology to educate this AI to help predict what would be the margins for a clinically significant prostate cancer, and where can you ablate to get 97, 98% likelihood of treating all the prostate cancer. And when they compared these different models, AI better encompassed the cancer compared to a 10 millimeter margin as well as a hemiablation. Much more so compared to a hemiablation. It was only a little bit better than a 10 millimeter margin, but it was better. And you can see why. So if we are talking about a hemiablation on the far right, if you're very strict about what a hemiablation is, this lesion crosses the midline. And similarly, in the lower side, the blue outline would be if you did a 1 centimeter margin around the MRI visible lesion, you're going to be missing half of this cancer. And so by integrating these different factors and using their AI methodology, I think this is a very promising thing towards the future of how we can more accurately predict our prostate cancer margins. But this is kind of challenging, right? So can we do this? So if figuring out where the exact margin is, and I didn't include a slide, but we know we have out-of-field recurrences. We know that we're not 100% with our ability to identify cancer. So a little tongue-in-cheek, but if the margin's so difficult, why don't we just treat the whole prostate? Well, we are here for a focal conference, so that's one reason. But cancer control, as I'm going to show in a second, is really not significantly better with a whole prostate versus subtotal ablations. And this is primarily comparing from trials looking at HIFU and cryo, because those are the two methodologies that were really used for whole prostate ablation. But in this study of 200 patients with men who had HIFU, there was really no difference in residual cancer rates after biopsy. In another study looking at cryo from the Cold Online Diet Registry, with about 900 men included. It was a matched pair analysis with 166 men in each group. And there was no difference in 2-year or 5-year biochemical recurrence-free survival in men who had whole gland versus partial gland ablation using multiple different BCR criteria. Looking at other studies that looked at focal or hemigland HIFU compared to whole gland HIFU or TULSA, the differences in cancer control were not that different, and the freedom from radical therapy is not that different. All of them are high 90% for freedom from radical therapy. So whole gland versus partial is not significantly different. So that doesn't really lend towards doing a whole prostate. And similarly, whole prostate ablation we know has increased side effects. So back to that original study, the same 200 patients, but they found worse incontinence in whole gland ablation, same impact on erectile function, but more complications. And this is one of the reasons why we're not recommending or people don't do whole gland HIFU anymore, is because there's significantly increased risk of post-procedure endoscopic surgery. So it was pretty much twice the number in this cohort. Similarly, another study looking at 300 men. This was a combination of HIFU and cryo. 200 had focal therapy, 100 had a whole prostate therapy. And really what they found was a significant impact with whole gland therapy on erectile function. There was a trend a little bit in the urinary function, but really in erectile function, there was an acknowledged significant benefit. And I'm kind of selecting just a few exemplary studies. There are many studies that kind of look at this and show these points. Similarly, 12-month recovery of intercourse. This is from that cryo online cold registry. Odds ratio was 2.1 in favor of partial gland cryo for increased preservation of erectile function compared to whole gland cryo. So usually we avoid whole prostate ablation for two main reasons. With HIFU, it's because they have significantly worse urinary symptoms and additional procedures are required. With cryo, because of the increased risk of impotence. There are exceptions to this, so if someone has bilateral disease, it's probably reasonable to consider whole gland therapy. If the patient's not concerned about their erectile function preservation, whole gland cryo would be very reasonable. Didn't have any significantly increased changes in their urinary function. And finally, for those with significant BPH symptoms, whole prostate ablation can improve their LUTs in addition to treating their prostate cancer. So I don't have a whole lot of data to talk about in terms of regional ablation. But I think this is a provocative study, because there isn't any. I mean, that's really why. This is a provocative study. It's a systematic review looking at 10 studies of TULSA, where they were able to map the amount of tissue that they treated and correlate that with the freedom from salvage-free probability. And so the top graph is salvage-free percent, while the x-axis is the planned ablation fraction. You can clearly see an upward linear line where the more tissue that's ablated, the higher the freedom from salvage treatment. In the bottom right graph, the potency preservation is the top, so 100% potency, so no impact on sexual function until we get up to about 80, 85, and then as we have an increasing rate of tissue treatment, there's an increasing loss of potency. So I think this is not definitive, but I think this can definitely be evaluated in further studies. As we're getting more computer-based tracking, as well as computer-based treatment in different forms of HIFU, including TULSA and transrectal HIFU, we'll be able to measure this and determine more if subtotal ablations, or what level of prostate cancer, what level of tissue ablation, or how much of the prostate we should be ablating to get complete cancer control or maximize that trade-off between cancer control and impact on erectile function. So, kind of the graphic version, we have pretty minimal miss. So if you just ablated by the MRI, we know you're going to miss tissue. We know that now based on our whole mount comparisons, but there really is a lot of room here. We have excellent cancer control with focal and ablation therapies. With the side effects, it's really only once we get up to that 85, 90, 100% of the prostate being treated that we get significant side effects. So there's a whole lot of room here in the middle for us to find what the optimal ablation size is for prostate cancer. So quick takeaway points in summary: cancer control, it remains our primary concern. I think we all need to remember that. Defining the best ablation zone is ongoing, but at least a 1 centimeter margin around the MRI visible lesion is highly recommended. Subtotal ablation is not worse than whole prostate for cancer control, so we don't need to treat the whole prostate. Avoiding vital functional structures is imperative if whenever possible, so subtotal ablations have less functional impact than whole gland treatments, and sparing the neurovascular bundle if there's no clinically significant disease in that area is of paramount importance. And finally, tailoring the ablation zone given the above factors is, I think, all of our goals. As computer modeling improves and we are able to track our treatments, I hope that we will be able to define what is that ideal ablation volume. Thank you.